morning. I can't see myself, so I'm hoping you can see me. And could you raise your hand, group watch, could you raise your hand or wave or jump up and down to make sure that you can hear me? Is anybody hearing me?
I see waves, but we can only see a few sites.
You can see a few sites, and they're waving, that's good. All right, well, good morning, and thank you for joining us for the third annual Behavioral Mental Health for Your Family and Community IVEN. It's hosted by NDSU Extension and presented by Prairie St. John's. The first year, we hosted 186 participants. Last year, 242 people joined us for the second annual Behavioral Mental Health IVEN, and we secretly hope that we top 300 attendees for this event. We'll report back to you next year when we come together again, so plan to attend next year and make sure you bring your friends, because next year we'll secretly want 350 people, so that's how we are. Another way to find out about how many people attended, and even more importantly what's happening in the world of mental and behavioral health, is to visit our websites. So the NDSU mental health page, on that we list agencies, publications, and opportunities for both the general public and for professionals. And that is at http, you know, the whole www business.ag.ndsu.edu/CFF. And when you get there, on the left-hand side, there's a little line in the left-hand navigation for resources for mental and behavioral health. So check that out. And Prairie St. John's has a very full website of their diverse services, and that is at https://prairie-stjohns.com. And of course, you can Google those things too. Our plan is to take the recording of today's speakers and put them on the mental health website so that they can be accessed by anyone needing this information. So please take note that this information will be available for your school principals and superintendents. Many have used these sessions later as training opportunities at their schools. So be sure and mention that to your local educational people too, because we all know that counselors benefit from this, but also teachers, bus drivers, food service, all the folks who work with kids. And we know the more eyes that we have on our students and our families, the better, to get them help at the right time. So that you also have access to some PowerPoints, and those will also be on the mental health webpage after our Easter break. So before we begin, I want to be sure everyone at every site has signed in. Make sure you sign in on our sign-in sheet, and if you're law enforcement, sign in on the post sign-in sheet, the post board. If you're law enforcement, note that today the first 2 hours are covered by first two speakers are covered by clock hours or your post board accepted. The third speaker is not, but we hope you will stay and stay with your community and listen, because we know you are the first face on the scene when there's problems in our rural areas. So please hang with us. And then the second item I'd like to draw your attention to is the evaluation. Please fill out the evaluation and leave it with your host site. These really help us. We pick our topics from what you ask for, so make sure you're noting on the evaluation what you'd like to hear more about in the world of behavioral mental health. We also love to hear that this made a difference, or that you're changing a practice because of what you heard today. So be sure and list your comments. Our first speaker today is Gina Scheffler, and she will address geriatric mental health. Gina is an adult inpatient therapist at Prairie St. John, and she completed her BS in emergency management here at NDSU and her master's in clinical mental health counseling at MSUM. Then we'll have a short break for you to stretch or participate in the activity if your site has an activity plan from 10 to 10:15, and then please be back in your chairs at 10:15 so that we can keep on schedule. And then Beth Brantner will address substance abuse issues and concerns after the break. She's a licensed clinical counselor and a licensed addiction counselor, also from Prairie St. John's. And Beth will present until about 11:15, and then Monica McConkey will take over and talk about a topic that is really getting some traction this year, farm stress. And Monica is the Director of Business Development. She has over 20 years experience in the behavior health field as a counselor, program supervisor, and administrator, and her work has been primarily with child and adolescent populations. And Monica grew up on a farm, so she knows what she's talking about. Well, they all do, trust me. And then I just want to mention that the Ivans are noise sensitive, so if you make noise at your site, then your site will be shown on the monitor. So please keep that in mind and turn off your phones or other devices that might interrupt and put you on the spotlight. So without further ado, I'd like to introduce Gina.
Good morning, everyone. Thank you, Kim. As Kim mentioned, I did complete my undergrad degree here at NDSU, and then I went on to MSUM. I completed all my clinical hours for internship and practicum at Drake Counseling and Lakeland Mental Health in Moorhead. And then I did internship hours at Prairie St. John's in Fargo, where I continue to work today. I work on the adult units, so anyone 18 and older. We do get quite a bit of older adults coming into our hospital, however, not as many as obviously younger adults and middle age. I'd like to thank Kim and the NDSU Extension Service for inviting me to participate in this training today. It's really important that we can get this information out to the public, and I'm so thankful that all of you were able to join us. So with geriatric mental health, today the goals are to cover the importance. Why do we need to know about this? Why is this important now? We want to look at barriers to care. What's preventing older adults from accessing resources, taking medications, getting to appointments? We want to talk about different warning signs that an older adult may be struggling, looking for things that you might not otherwise know about. We also want to talk about where to go for help. Sometimes these resources seem endless, and knowing who to trust and who you can access is very important. We're going to talk about types of disorders, which is a very interesting part of this PowerPoint. We also want to look at suicide prevention in older adults. It's not often talked about, but it needs to start having this discussion. And then, of course, going over the resources as well. So the importance of geriatric mental health. It's getting increasingly more important. We all know the baby boomer generation is aging. They're getting older, they're beginning to slow down. In the state of North Dakota alone, there are over 90,000 individuals that are over the age of 65. That's a huge group, and it's going to continue to grow over the next few decades. Many of you know people who are 65 or older who continue to live in their own homes. They may still work, drive, live quite independently. However, at this age, people begin to slow down. They begin to have cognitive delays. Their physical limitations become increasingly more important. So we want to focus on individuals who are nearing or passing age 65 to help the continuation of the aging process. Many people believe that a lot of the things that happen to us as we age are normal, it's expected. However, it doesn't have to be normal. There are things we can do to make it easier for older adults to transition. Many individuals may fear losing their mind or even losing their memories with concerns about dementia and other disorders. A family history of dementia or seeing a loved one or a friend go through it is a very, very difficult time. But if we understand the basics of dementia and what we can do to help assist those people, their quality of life is going to improve. It's important to remember that for all the disorders we'll talk about today, with the right treatment, many older adults can stay in their own homes and they can continue to thrive. Please understand that most mental health conditions are treatable and the symptoms are going to be manageable with the right community support. So first I want to talk about other barriers to care. Ageism is a really big one that a lot of people don't acknowledge. Older adults are often a neglected population due to ageism, or the belief that getting older and feeling depressed is normal. It's important not to normalize losing one's friends, one's home, one's sense of self. These situations are very unfortunate and they don't happen to everyone. Think about the people you know who are older than 65. Think of someone who has a broad social network, someone who attends church activities, gets out and about on their own. Now think of someone who has limited family support. They may live in a care center, they may have very limited access to resources. two adults at the same chronological age can have very different experiences. From the clinical perspective, it's important to look at older adults from their biological standpoint. How are their bodily functions working? Do they have problems with their heart? Do they have problems with mobility? It's also important to look at their psychological age. Is their mind still there? Do they still have their memories? Are they still able to make choices on their own? The stigma about addressing mental health concerns is quite big in the older adult population. Many of them have an idea of what mental health looks like. They may have seen movies or TV shows. They may have had a sibling, parent, relative who was in the mental health system. Helping older adults understand that it has changed a lot. We access mental health care a lot differently than we did even a decade ago. So understanding that people are there to help and accessing trained mental health professionals is very important. Also in North Dakota, we understand the geographical constraints. Many people live in rural areas. They may be very limited to how often they can get to town or access a doctor or a therapist who's going to be able to work with them. Thinking about the weather, how much they have to plan to find a ride and arrange transportation. And then also, most people mean very well when they share concerns about mental health. However, sometimes people will reveal incorrect information about mental health. We want to make sure that older adults have access to appropriate information. Just like with physical health, mental health is constantly changing, and we want to make sure that the right information is getting out so that people are informed. So in the hospital, we talk a lot about baseline functioning. Every one of us has a baseline. It's how we normally operate. Do we take care of kids, pay our bills, go to work every day? When you're younger, you're going to start out with a pretty low baseline. You need almost full assistance to do everyday tasks. As you get older, your baseline will increase. When you reach full adulthood, you're able to operate freely and for most of us independently. However, once we get older, the baseline begins to drop. It's important to understand where someone's baseline is, especially from the clinical perspective, because the treatment professionals need to know where you normally function. If you deviate from that baseline, what do they have to do to get you back to where you're supposed to be? Also thinking the older we get, the baseline will drop a little bit, and that can be very difficult for people to accept. They don't want to feel that they can't drive anymore, that they can't go to their own appointments. We need to be supportive and encouraging to that, and recognizing where the baseline functioning should be for any individual. And also I should mention, within the hospital setting, there's an assessment called the CELS. It's a Coleman evaluation of living skills, and that'll provide a very quick determination for us to see if someone's able to return to their home. Sometimes entering the hospital, things have gotten so bad where your level of functioning really has changed. So being able to provide a CELS assessment for psychiatric patients can help the doctors and the treatment team realize maybe this person isn't able to return to the exact place that they were before, but with added help and more support, we can make something happen so that it's possible. So many of you know that we look at autism spectrum disorder as a spectrum. You can be at any spot on the spectrum at any time. We want to look at mental health the same way. Some people feel like they're free from mental health concerns. However, just like with the weather, it's always there. We all have mental health concerns. So obviously most of us want to operate on the left side. We want to be healthy, we want to be functioning. But different situations will pull us farther to the right, okay? You might have a job loss, a physical illness, you might have to have surgery, even the death of a loved one, losing a pet. All of these things will push us further to the right. We want to get back over to the left. We want everybody to operate where they feel that they're healthy. So helping people understand that throughout our lives, we're going to be moving up and down the spectrum. There's never a time where someone will just stay in the healthy box due to normal life situations. A big thing that we're talking about in the hospital right now is acceptance and commitment therapy. It can be very useful for people to realize that we have to accept our life for how it is. We can't look at things as good or bad, but truly just accepting our experiences and accepting our situation, which can provide a lot of relief for people who are struggling in different areas of their life. So this slide is going to look very full, okay? These are warning signs. Of course, this isn't an exhaustive list, but these are some of the things that you may notice changing in an older adult. We can go through these quickly. Anxiousness, very common for older adults. The brain starts to change and our ability to tolerate stress reduces as we age. So thinking about an adult who may be displaying anxiousness, irritability, or even memory loss. The next one, thinking of new problems with decision making. Someone who wasn't struggling with making decisions before, such as where to go to eat or what trip they want to take, if they start struggling with that, that could be a warning sign that something's going wrong. We also want to look at someone who's having difficulty concentrating or paying attention. Let's say you frequently go to church with an older adult, all of a sudden you notice they kind of stare out the window often, or when you're talking to them, it seems like they're glazed over, not really paying attention. It could definitely be a warning sign that something is right. A lack of interest in the usual activities. Someone who frequently goes to the casino, someone who goes to the library, someone who volunteers, they may not do those anymore. Asking why, saying something like, I noticed you're not doing these things you loved. Is there any way we could talk about this and see what's going on here? Sadness and depression, these are very, very common amongst older adults. Noticing someone whose baseline isn't sad, isn't depressed. We want to look at mood swings. People will refer to this as walking on eggshells. They don't know when the mood's going to change, and the changes can be pretty drastic. Chronic pain can actually be a sign of mental health issues. We'll talk about this more later, but for a lot of adults, it's easier to say my back hurts, my stomach hurts, my head hurts, than it is to say I feel lonely, I feel unhappy. So we want to look at chronic pain and how that could relate to mental health. They might have problems with money or with the police, falls, bruises, burns, incontinence, headaches, dizziness. All of these warning signs are signs that you can look at and write down. Take them to the primary care physician and start to see what could be happening, what's causing these changes, and what can you do. This next set of warning signs is much more common from what we look at in the hospital setting. This is a clinical perspective. Is the person withdrawing? Someone staying in the hospital may just want to stay in their room the entire time they're there. We want to know why. Why have they become so withdrawn from things they might have enjoyed? We also want to look at a drop in functioning. Whether it's at church, work, or school, why isn't this person able to do the things they were normally able to do? Problems with thinking, looking at their concentration, their memory, are they logical with what they're saying? Increased sensitivity to sight, sound, smells, or touch. A lot of people will start to avoid situations that they used to love to go to because the sights and sounds are so overstimulating that they would rather withdraw. They would rather isolate. And then, of course, apathy. It's a loss of initiative. You just don't have a desire to participate, and you seem very blasé about different things. Feeling disconnected. This is very common for older adults in care facilities, feeling like they don't know what's going on in their community or going on with their family. Some of these adults are really limited in their ability to access resources. Illogical thinking, they might be very exaggerated beliefs, kind of bizarre beliefs. It could be magical thinking, as if what a child would kind of act like. Something like seeing fairies on the nightstand or being very childlike. Nervousness is very common. They might have a certain fear or suspicion of doctors or family, even friends. Unusual behavior, things that just seem odd and very uncharacteristic for them. Sleep or appetite changes, and mood changes, which are, again, a dramatic change in feelings. So these risk factors on the left, these are characteristics at the biological, psychological, family, community, or cultural level that precede and are associated with a higher likelihood of negative outcomes. So risk factors are things that could end up harming a person. If we look at the risk factors somebody might have, we can better get an idea of what type of level of care they're going to be needing. On the other hand, we have protective factors, which are associated with a lower likelihood of a negative outcome. These are things that keep us safe. Within the hospital, people who come in with suicidal ideation, we really look at their protective factors as what's going to keep them safe when they leave here. What gets you out of bed every day? What keeps you going? These things could be having children or pet, having faith or religious beliefs. All of these things protect us as people, and they can be really useful from a clinical perspective. More protective factors that we can think about when considering the older population: are they able to live independently? That's a huge thing for people. Do they feel like they have the ability to make their own decisions, to verbalize their concerns? Can they access resources like doctors and medical places? Again, do they have faith, family support, social support, going to church, going to casinos, going wherever they go, volunteering? All of these things are important. We need people around us because that helps keep us going. It gives us something to look forward every day. Good physical health and good emotional health. These are protective factors. If one area of your life starts doing not so well, the good physical health and emotional health will help you get through it. And then, of course, does the person have an education? Having an education does increase your likelihood that things are going to be okay. You may have more knowledge or more ability to access things than somebody who might not have an education. And then, of course, financial resources, being able to pay for your appointments, for medications, for trips, maybe to surgery. Financial resources, when you don't have them, can be have a huge negative impact. And then, of course, secure attachment with others. We want to make sure that the relationships around older adults are secure and that they feel safe in these relationships. Thinking of a care facility where maybe the staff changes frequently, your loved one might not feel secure with the people who are coming in and out all the time. And then again, these are the risk factors. Living in a care facility, not being able to communicate your thoughts, having reduced mobility, needing extra help to get to appointments, a loss of family or a loss of friends, limited family support or limited social support, poor physical health, poor emotional health. You might have a cognitive delay, financial concerns, or poor attachment. So you see how the risk factors and protective factors greatly mirror one another. And we can see how many risk factors do we add up versus the protective factors that any individual has. So where to go? Fortunately, there are a lot of resources available. In the state of North Dakota, they're a little bit more limited than other states in how many different individual places there are. However, there's great online screening tools at Mental Health America of North Dakota. These will screen for depression, anxiety, bipolar disorder, psychosis, post-traumatic stress disorder, alcohol and substance abuse, and even eating disorders. So if you go onto Mental Health America's website, you can Google these screening tools and find a way to invite an older adult to help you take these together, and that'll provide you direction, which way you might need to go, depending on what the results are. And then, of course, FirstLink. They provide the suicide hotline for the state of North Dakota, and it's also an information and referral line. FirstLink can connect older adults with a lot of resources, and it's very easy because it's over the phone. And then, of course, within all of your communities, there's likely local agencies that will be able to provide mental health services or social services for adults. Another useful resource is Choice IND. This is actually one that I just discovered. Resources for those who are aging or those who are disabled. It can provide a lot of information on different places, even nationwide, that you can access more information. So I definitely encourage all of you to use these resources when thinking about someone in a particular situation that they might be struggling with. The one that we have up on the screen here is the Alzheimer's Association. There's honestly just countless resources to go through on here. So this is a map of the state of North Dakota. These are the human resource centers. The one that we have here in Fargo is called Southeast Human Service Center. These agencies will provide even more community support and mental health services. They also have a crisis line. And this organization is the starting point for people who need long-term mental health care. Within our facility, some people go through Southeast to get to the state hospital, which can provide more mental health services for adults who may be struggling. And another important topic is thinking about older adults who might be experiencing abuse or even neglect. A lot of you are going to be mandated reporters for older adults to report this. However, it's important to remember that anybody can report it. Always trust your intuition. Either call this number. You can talk to your local social services center and tell them what's going on. Tell them what you see. Don't let this go unnoticed, because if somebody is struggling with abuse or neglect, it's really important to get the information out there so that something can be done to help them. Even thinking of someone like a banker. Bankers might notice very unusual spending habits. They might be able to lead someone to signs of abuse or even neglect. Thinking of hairstylists, they might notice people are missing appointments or skipping appointments. They might notice bruises or scratches. Hairstylists get very intimate with people, so seeing those things and being able to report it, feeling like you can report it and there won't be any negative repercussions for you, you will be helping someone out. So now we're going to get into more of the treatment side of things. Please understand that with this part of the presentation, it really is from a clinical standpoint. So we always want to start with a medical checkup. Many of you might not know this, but a urinary tract infection or urinary retention can make a person seem like they're going crazy. Just something as little as an infection could lead to a lot of psychological changes and a lot of behavioral changes. So at nearly any walk-in clinic, you can have a urine test done, and being able to test for something like that can rule out a lot of things. And obviously, if someone is struggling with an infection, we want to be able to address that right away before we get to the next level, which is obviously therapy and medication. Talking to older adults about therapy and medication can be quite difficult. They might have a lot of reservations about the idea of seeing a therapist and talking about their problems. It's very common for people from Northern European countries to kind of want to have a stiff upper lip, keep those things inside and not share them. But as of course time goes on, we realize that that doesn't help people. It keeps the illness within us, and we're not able to move past different things that we might be struggling with. And specifically with medications, the reason that the majority of psychiatric facilities closed was because of the advent of psychotropic medications. There's a whole list of medications that can be tried for different disorders, different things that people are experiencing, and that's actually why people don't live in psych facilities anymore. They're able to return to their communities because of these medications. The medications will get them back to normal, where their baseline functioning is, and ideally it will keep them there. The scary thing about medications, however, is sometimes they work really well, and an older adult or even middle-aged or a child will say, I don't need these anymore. They throw them out the window. And that's one, from the hospital standpoint, we see a lot of people come back in. They might have gone a week, 2 weeks, even a couple months, but then things start to fall apart again. We want to get them back on their meds. And more so, keeping them from going off their medications is going to be really important in keeping older adults in their own homes. So talking to older adults about the medications, encouraging them to write down the side effects that they're experiencing. Their doctor will look at their medication regimen from the standpoint of, are you able to tolerate the medicines? Or are the side effects getting to be too much for you? Medication changes can be made under the discretion of the doctor. And when you change the meds outpatient, it prevents you from having to come inpatient. Oh, and then of course, day treatment. Some people will need a little bit more care for their mental health. There's different day treatment options throughout the state of North Dakota. There's St. Alexis Medical Center in Bismarck, Sanford and Fargo, of course, Prairie, St. John's and Fargo. Day treatment can be the next step before hospitalization would be required. Can we get things back on track before they would have to go inpatient? Coming from the hospital, we understand that a hospital stay is very stressful. You're in a new environment, you are in a new bed, you're surrounded by new people, and it can also be costly. We want to try to keep people out of the hospital as best we can, knowing that it's not always preventable, but if we start with the medical checkup, start looking at therapy and medications, and even going to day treatment, the final step, which is hospitalization, can oftentimes be avoided. So these are different disorders that impact older adults. These are the ones that I will be speaking about today. Of course, there are more than this list. We have things like personality disorders, there's different neurological disorders, but this list is probably the closest to what you would be seeing out in your communities. Psychosis, dementia, anxiety, substance use, and depression. And then along with depression, we'll also talk about suicide in older adults. And I just want everyone to know, when we do get to the dementia portion of this presentation, if you've lived with someone who's had dementia, definitely feel free to tune me out. You've lived it, you know what it looks like, and it can be very painful to hear someone talk about it. And the same with suicide after the depression portion. We'll talk about suicide in older adults. If you know an older adult, or if this is something very personal for you, feel free to tune me out, because I understand that can be very, very difficult. So when we look at psychosis in older adults, the elderly, especially those who are 85 and older, are most likely to have an increased prevalence of psychotic symptoms. Psychosis as a whole, you'll experience different things, a lot of times delusions. These delusions may be paranoid in nature, thinking someone's out to get them, thinking someone's stealing their money, coming into their home. You may also have delusions of grandeur, where you feel you're the king of a country and you need to go reclaim that. These delusions seem very bizarre, and they are. It's something that's happening in the brain. With medication, we can reduce those delusions and get the person back to baseline. Then of course we have hallucinations. Hallucinations are things that someone sees that no one else can see. Things that someone hears no one else can hear. Sometimes people will also have tactile hallucinations, where they feel something's on their skin. They may feel that someone's touching them, or someone's with them in the middle of the night. The hallucinations might be seeing things in a room that nobody else would be able to see, hearing voices in their head. With hallucinations as well, medication can reduce that. And therapy is also very useful for people who are experiencing psychosis, because psychosis in itself is very scary for a lot of people. Some individuals, and oftentimes older adults, will have a very pleasant psychosis, where they feel very happy and almost euphoric with the delusions or hallucinations that they're experiencing. Oftentimes older adults who are psychotic and then get put on antipsychotics will actually hit a depression once the psychosis wears, because the feelings of being really euphoric were good for them. And now that they lost that, they might feel a little bit depressed mood. But like I said, for most people, hallucinations are very scary. The way I explain this to patients is when you're pulling up into a parking spot at a store, and you put your car in park, and then all of a sudden it feels your car is rolling backwards, but really it's just the person next to you leaving. Imagine things like that happening over and over again, where you see these things and they feel so real, but nobody else believes you. That's what psychosis feels like for a lot of people. It feels really scary. So trying to understand it from that point of view when somebody is experiencing psychosis can help you show more empathy and more understanding to somebody struggling with this. They might also have a thought disorder, being very distracted. We call it responding to internal stimuli. When there's a hallucination or something going on, their thought content's going to be a little bit off. They're not going to be able to focus on what you're saying if they're hearing something else going on. And then of course, insight. Some people who experience psychotic symptoms have a lot of insight into what's going on. In an older adult who may have struggled with schizophrenia their whole life, they'll probably have increased insight into what's happening to them. Older adults who come into the hospital experiencing psychosis are often really good at hiding it from professionals. It's almost as if they're trying to keep it together because they don't want to be medicated, or they don't want to have to stay there a longer time. But usually psychosis, will emerge to a clinical professional, will be able to help them get back on their medications, get back in therapy. So psychotic symptoms, if not treated right away, will increase the morbidity of an older adult. So we really want to address these concerns, getting somebody to their local counseling center, getting them to a hospital if things are getting serious. Doing that as early as possible is really going to help their outcome. So understanding that psychosis can come in a combination with a lot of things. A lot of people who use substances, especially methamphetamines, will become psychotic based on the drug use alone. Some older adults who have been using alcohol may also start to show psychotic symptoms. Mood disorders, someone with bipolar 1 or bipolar 2 could also become psychotic. Those with dementia may have psychotic symptoms. Of course, neurological conditions, thyroid problems, diabetes, or even sleep deprivation can lead to psychotic symptoms. And keep in mind, these symptoms may be very minimal. Seeing something in the middle of the night when you haven't slept in a few days, it's not uncommon. And then, of course, treatment with medications primarily, along with psychotherapy, will really, really help older adults get out of their psychotic episode and back to their baseline. So delirium's getting pretty deep into the spectrum of mental health disorders, but I do think it's very important to share this with you all because it can look a lot like psychotic symptoms, it can look a lot like dementia, and it's very common during hospitalization. So the key distinguishing feature of delirium is that it's a new problem. Adults who are hospitalized or who have had surgery, it's very common, about 50% of them will experience delirium afterwards. This is often misdiagnosed. People think, what is going on with this person? Why are they displaying all of these unusual behaviors, all of these weird symptoms? Looking at it as disorientation, not being able to focus, having mood lability, anxiety, or even impaired speech. Again, the key factor is that it's going to be a really sudden onset. And for a lot of adults, it's going to be more pronounced in the evening. We call this sundowning. It's where the behaviors really emerge later in the day. So delirium is very easily confused with dementia, but dementia is a very slow onset. Delirium happens in a matter of hours. Delirium is usually temporary, lasting hours to days, but for some people it will last for weeks. It's very expensive and it does lead to a shorter lifespan for those who are experiencing it. And I wanted to tell you about delirium, so if you know of an older adult who's going to be having surgery or who's going to be able to go to the hospital, talk to their doctor. Has this person ever had psychotic symptoms in the past? It's also common for people who are taking narcotic opiates for pain. They're more at risk to experience delirium. Anyone with a history of delirium or people who haven't been sleeping well. So if an older adult hasn't been sleeping well prior to surgery, it's more likely that they'll experience delirium. This is the part of the presentation, like I said, if you feel like tuning me out, I don't blame you whatsoever because this is a very difficult topic for many people. Dementia is an overall term for a set of symptoms that are caused by disorders that affect the brain. It sounds very clinical, it sounds very basic, but as we know, it's a very dark, very, very unpleasant disorder. So the symptoms may include memory loss, difficulties with thinking, problem solving, or language. These symptoms are going to be severe enough to reduce a person's ability to perform their everyday activities. A person with dementia may also have a lot of changes in their mood or their behavior. The person who they once were, you don't see that anymore. And of course, dementia is progressive. The symptoms do get worse, and what's happening is the brain cells are getting damaged as time goes on. For those of you who haven't witnessed an adult who's had dementia or Alzheimer's, there's a movie titled Still Alice, in which the lead character gets early onset dementia, or early onset Alzheimer's, I should say. And I definitely recommend this movie because it can really show you what it feels like for the person and those around them. Sometimes it's easy to ignore these painful disorders. We consider ourselves lucky to not have to go through it or not have a family member go through it. But as care providers, we need to know about these disorders and the symptoms that we're going to see with them. It's also important to remember that dementia is not a very specific disease. It's more of an umbrella term. So other diseases can cause dementias, such as Alzheimer's, vascular dementia, which is caused from strokes, Lewy body disease, somebody who experiences head trauma, especially in the frontal lobe, right behind the forehead. There's Creutzfeldt-Jakob disease, Parkinson's, and Huntington's. So these conditions all have very similar and overlapping symptoms. So knowing the symptoms can help you understand what's going on with an older adult better. So from a clinical standpoint, dementia is just an overall set of terms for symptoms that are caused by disorders affecting the brain. Like I said, problem solving, language, mood, those are the big ones that are going to be impacted. So the first 3 stages of dementia that we have up here are almost considered pre-dementia stages. The first one itself is where there's no problems with cognitive impairment or memory. With somebody who's experiencing dementia, it's really important to know about their past medical history and even family history if you can. Some people years and years ago experienced dementia, nobody knew what was going on. 100 years ago, they would likely be put to a psychiatric facility for their impaired thought, their impaired mood, or their impaired behaviors. So understanding the family history and the person's history will be really important. So in the first stage, they're probably not going to have any behaviors or any signs. The mild memory decline may seem normal, right? It's often for someone even my age to forget their keys or forget their phone. These are basic things. But once somebody starts forgetting the names of the street that they live on, the names of a cousin or an old coworker, that's when you notice the dementia is really starting to take form. The third stage, you're starting to get lost easier, a poor performance at work, forgetting names of family members, close friends, nouns that are very common for you to know. And you might also have difficulty retaining information, and losing or misplacing important objects, very common in stage 3. Stage 4 is considered mild dementia. You have a decreased knowledge of current events or even recent events, difficulty remembering things about your own personal history or someone close to you. You might not be able to handle finances as well. As I mentioned earlier, this is something that a banker, even a bank teller, would be able to notice and may be able to say something to a family or friend. Difficulty arranging travel plans, feeling disoriented, not quite sure where you are in very familiar locations, and you might have difficulty recognizing faces and people. Just like with psychosis, it's important to understand that people experiencing dementia are having a hard time. Imagine if you weren't able to remember someone who you felt was very familiar to you or getting lost. Understanding the frustration they may feel, the anger, the fear that somebody might be feeling is very important for care providers. Stage 5's moderate dementia, you're going to start to require some assistance during this stage. You're going to start to forget major details of your own life and feeling even more disoriented about place and time. And then, of course, stage 6 is moderately severe. These behaviors are going to start to look more delusional, like what we were talking about with people experiencing psychotic symptoms. The behaviors might start to get obsessive. You've all heard the term obsessive compulsive disorder. When we have these obsessive thoughts, it's things that we can't let go of. We keep ruminating on the same thing over and over again. For people with OCD, it could be that their house wasn't locked properly and they're very obsessed over the fact that someone's going to break in. With the obsessions comes the compulsions. Going back to your house 6, 7, 8 times to make sure that door is locked. The compulsions help the obsessions in theory, because we feel if we keep checking on things, we'll ease our mind. So obsessive behaviors for an older adult experiencing dementia may be wanting to check their bank account several times a day if they're concerned about losing money or misplacing things. And then anxiety, aggression, and agitation. These are very difficult symptoms, especially for family and close caregivers, and even a loss of willpower, where they really start to almost succumb to the idea of dementia, and it seems like their will to live is getting a little bit lower. And then, of course, severe dementia is the last stage. It's losing the ability to speak. You'll need help with walking, eating, and even using the bathroom. But by identifying dementia in the earliest stages, you may be able to seek medical treatment and slow down the progression of these final, more unpleasant stages. So even though all the stages are going to be progressive, in certain situations of dementia, not Alzheimer's, some dementia can be reversible. If it's more towards, a thyroid issue or diabetes, we can reverse those a little bit easier. So being aware of these stages and understanding that you need to be quick in reacting and seeking help With dementia, as a whole, we don't like to address that. We kind of like to ignore the problems. And even with the individual struggling, they're going to try to hide these things from others. They might stop doing activities they once did because they don't want people to notice what's happening. You may notice someone's house filled with notes reminding them to do things, numbers everywhere. To us, it may seem a little bit bizarre, but to the individual, they're trying desperately to hide the fact that their brain is changing. So back to a more positive side of dementia, there are ways to manage the symptoms of dementia. Modifying the environment, make things very easy. Rather than looking at all the challenges an older adult is struggling with, make it harder for them to be challenged by their own home. What can you do in their home to make it safer and more accessible for them to live in? Modifying tasks for an older adult, finding different healthcare accessories that can make things easier, such as a walk-in tub or having a larger remote, posting signs around the house, helping remind them to do different things. Like I said before, recognize the lonely and empty feelings that someone's experiencing. If there is a family history of dementia, it's likely the person has seen this in someone else and they have an idea of what's going on. Always remember that. Building on strengths of the individual, whether you're an infant or 90 years old, we always want to look at the strengths someone has and build on those as much as we can. We want to reduce their deficits. We want to reduce the things that aren't going so well and really recognize that there's still things that are going to be okay. And then of course with dementia, probably one of the ugliest sides of it aside from memory loss can be the behavioral problems. However, if behavioral problems are addressed really quickly, they can actually be reduced and even eliminated. So that's why accessing healthcare, accessing providers, looking up information on the internet, figuring out what you can do when these behaviors emerge to reduce and eliminate those. So anxiety, much like depression, is very prevalent amongst older adults. Like I said before, somebody may be experiencing depressive or anxious symptoms, but they'd rather say that their back hurts or their head hurts or that they're feeling tired. We don't like to admit that we're experiencing anxiety or depression. However, as we age, our brain changes a lot and our ability to tolerate stress changes. We start to worry about things. A lot of these things are very common to worry about, such as finances, our physical health, family changes. We also get anxiety about our mobility. I have a pain in my hip. Will I need a cane one day? Will I need a walker? Will I need a wheelchair? And then of course, cognitive decline, not feeling as sharp as you once did, not being able to keep track of things as you once did. These things provide a lot of anxiety for older adults, but it is important to remember that there is treatment. There's different medications older adults can take to help reduce the anxious symptoms. There's psychotherapy. A therapist can get to the root of what's causing this anxiety and teach an older individual different ways to cope with the anxiety. A big one that we use in the hospital is mindfulness, taking time to be very present in the moment. Some people think that mindfulness or meditating is where you clear your mind of all thoughts, but it's actually where you just focus on the exact moment that you're in. So a lot of you have experienced a time where you drove home and you probably don't remember how you got there. We put ourselves in autopilot so often. Someone may be speaking and you're nodding, but not really listening. Mindfulness breaks you out of that and just keeps you in the moment so that you feel very present and very connected. So thinking about anxiety as concern of the unknown, we want to bring our mind and our attention back to the moment, and that can definitely help reduce the anxious symptoms someone's experiencing. Another thing with anxiety, always keep in mind that there are times in our lives where it's actually important for us to be anxious, and it would be odd if we weren't anxious. Something like traveling on a plane or me giving a presentation. Anxiety is common and it's not a bad thing. So many people look at anxiety as I need to stop being anxious, I need to stop this. Understand that the brain and the body gets anxious for a reason. So not looking at it as a bad thing, looking at it as something that's a part of your life and something you can learn to work through. So anxiety disorders, we have panic disorder, somebody who feels very panicky and has catastrophic thinking, imagining that the worst thing is going to happen and then the body responds as such. Obsessive compulsive disorder, which we've already talked about, Post-traumatic stress disorder, someone who's experiencing a traumatic event will have kind of a fear over their safety that lives within their brain, always feeling that something bad is about to happen, being easily startled. Phobia, it's an extreme fear of something that's very unlikely to happen. So the idea that a spider could eat us, very unlikely, but a lot of people have different phobias. Always keep in mind these fears are irrational, but there is help to reduce the fear we have towards those things. And then the most common one that would be diagnosed for an older adult would be generalized anxiety disorder. And it's just a chronic exaggerated worry that something bad is going to happen. So looking at ways to manage anxiety symptoms, definitely meeting with a therapist, someone who specializes in anxiety disorders can be very helpful. Taking medication, practicing mindfulness, keeping yourself in the present moment, getting enough exercise, and then of course the big one, limiting alcohol and caffeine. The body doesn't need alcohol or caffeine or nicotine, and quite frankly, it does much better without it. People who are experiencing anxiety symptoms may do well to not drink, smoke, or drink caffeine at all. And then, of course, getting enough sleep. You always want to get yourself into a routine where you feel like you're able to operate on a consistent pattern. Somebody who's kind of late for everything or feels disheveled often, that's just going to increase the anxiety symptoms that they feel if they're not organized. Of course, Beth is going to be doing a presentation in a few minutes after me about substance use as a whole. I really wanted to focus on a few key points for older adults in substance use. First of all, older adults are grossly undertreated. We want to recognize this age group. As this age group gets older and as the group itself gets bigger, these are things that we need to pay attention to. Older adults are often not to seek services in traditional settings. They might talk to their pastor, they might talk to a coworker, but as far as coming to a place like Prairie St. John's, it's not as common for an older adult. There's also comorbidity with other mental health or medical problems, and oftentimes it's used to escape pain or suffering that somebody might be experiencing. And of course, older adults will tend to justify their actions. They may feel that the alcohol is good for them or that it has some benefit in some way. So older adults will use alcohol to escape social isolation. These topics are often avoided with primary care physicians. A lot of primary care physicians will avoid the topics of substance use, and they will avoid topics of mental health concerns. So it's important to seek the right professional when somebody's struggling with this. Substance use can lead to memory loss, disorientation, or even falls, which would also lead someone to hospitalization or even nursing home care. Along with justifying the behavior, a lot of people who take medications prescribed by a doctor will minimize the negative reactions to it because they were prescribed. They feel like because they are prescriptions, it's okay. Someone wrote their name and signed it, and I'm okay to take these. But older adults do abuse prescription medication as well, and a lot of doctors are more willing to prescribe older adults more opiate types of medications because of the lower risk of them getting addicted. They're already in the later stage of their lives, so they're a little bit more prescribed than they would be for a younger adult. Of course, treatment options, I know Beth's going to go through these as well. We have NA and AA meetings. At Prairie St. John's, there's intensive outpatient treatment, which is more of an evening course for people. We have our partial hospitalization, which is a day treatment. And then, of course, people who need to be in a more secured environment can do low-intensity residential or high-intensity residential. But for all of these, it's important to start with a substance use assessment, talking to a licensed addiction counselor anywhere in the state of North Dakota. They can complete the assessment and help you decide which level of care would be best for you. And along with the substance use assessment, most insurance companies will require that one of these evaluations is done in order to pay for this care. Guidelines for alcohol use: no more than 1 standard drink per day or 7 standard drinks per week. This is for older adults. Keep in mind that this is a little bit less for women. This guideline is actually for older men. And then, of course, no more than 2 standard drinks on any drinking day or occasion, such as wedding or New Year's Eve. Those are the guidelines that SAMHSA put out for older adults and alcohol use. very quickly, running out of time. So depression affects 15 out of every 100 adults over age 65. Like I said earlier in the presentation, we can't normalize depression for older adults. We all know people who live into their 70s, 80s, or even 90s who don't experience depressive symptoms. So the idea that depression is common or expected, we really need to reduce that. Depression is treatable. You can become freed from your depressive symptoms with medication and treatment. And then, of course, the social stigma surrounding the treatment. As you can see, we have electroconvulsive therapy. We call it ECT. Back in the day, they called it electroshock therapy. We all have very unpleasant images of what this could be. ECT is just a very low, it's a very low risk treatment for people when they've tried everything else and the depression won't break. It's done under anesthesia. There's a doctor, a psychiatrist, a lot of people in the room, and it's used for people who haven't been able to be treated in other areas. So even thinking about the scary images of ECT, we understand why people are so slow to access mental health services. These are different depressive symptoms that someone may experience. Keep in mind that it's always going to be more than sadness. So managing depressive symptoms, we want to look for a medical checkup right away, rule out any medical problems that may be happening, and even some medications can increase depressive symptoms. Medications can also help manage depressive symptoms, and they help older adults. We want to help older adults understand how many to take, when to take them. Depression medicine is a big one. People start feeling better and they think, oh great, I don't need the medication anymore. They throw it out the window and a few weeks later they're back where they were, or even worse than where they were before they started taking the medication. We also want to look at therapy, helping understand where these depressive symptoms come from, being able to process through these things, with a licensed therapist. And then of course, electroconvulsive therapy, it's used when all of the other options don't work. So as we get closer to the end here, I do want to talk about older adults and suicide. There is research that shows that older adults are the highest population to die by suicide. Those numbers are actually from the around 1990. The numbers that we'll show here are from the American Foundation for Suicide Prevention. And older adults are actually the second highest group to die by suicide. However, 25% of the nation's suicides are by adults over 65. And white men over 80 years old are 6 times more likely to die by suicide than the average population. Most people welcome care, concern, and support. However, they're afraid to access services because they don't know what's going to happen. Think of depression as a dark cloud that comes over your head. It clouds your judgment, it clouds your mood. Things don't seem as happy as they once did. With medication and therapy, that cloud can be removed, but it's important to access resources and always take suicide very seriously. These are different questions that you can consider when looking at somebody who may be thinking about suicide. These suicide statistics are for all ages, not just older adults, but it's the 10th leading cause of death in the U.S. Nearly 45,000 Americans die by suicide every year. For every suicide, 25 people attempt, and it costs $69 billion to the U.S. annually. So this graph is going to show deaths by suicide for all ages, not just older adults. As you can see, half of the deaths are due to firearms. So if we think back to the number of 45,000 Americans dying every year by suicide, we could have reduced that in half just by taking firearms out of the homes. Within the hospital, it's very important before patients are discharged that firearms are secured. We don't want somebody to have access to those. Talk to someone, say, I'm really concerned about you. Is there any way we could remove these from the home so that I can feel more at peace knowing that you're going to be okay? Some people are very protective over their firearms. They don't want anyone taking them from them. So come at them from the angle of empathy, showing that you care, showing that you have compassion for them. And always remembering that with suicide, ambivalence is usually very high. People are on the fence. Suicide is a means to an end, but the end is that you're not there anymore. We want to make sure these people are still there, giving them an opportunity to access treatment, access therapy. If you're using a firearm to die by suicide, firearms are not very forgiving. There's usually not a moment where you can stop and change your mind. Once the trigger is pulled, the results are oftentimes fatal. So understanding this isn't from a controversial standpoint, simply a clinical standpoint, that firearms continue to be the most lethal method for suicide in the US. If someone you know is struggling with depression, removing those firearms can save their life. Of course, call a crisis line if you ever are concerned about someone. Call 911 if there's imminent risk, or go to an emergency room, or better yet, a psychiatric facility. Psychiatric facilities are trained in mental health and mental health alone. Whereas emergency rooms, they may have car accidents, heart attacks, trauma coming in. Your loved one's going to get psychiatric care quicker if you come right to a facility such as Prairie St. John's. And of course, care strategies for older adults. We need to have more training, like the one that we have today. We need to look at prevention. How can we keep older adults in their home? How can we help them function better independently? We need to look for sustainable policies. This generation is getting bigger and they're getting older. We need to have more resources available for people to access and more age-friendly services. A lot of older adults don't want to do mental health groups with younger adults because they feel such a big disconnect. So creating programs specifically for older adults is very important. As I said before, early diagnosis is very important in changing the trajectory of someone's life. We can greatly improve their quality of life if we get in early enough. It's almost like dental care. You know when something's wrong, but you put it off until the bill gets into the thousands. Providing long-term support to caregivers, helping caregivers access correct and current information, and especially helping caregivers feel supported in what they're doing. We want to optimize physical and mental health by identifying and treating physical and mental health illnesses, and then detect and manage challenging behaviors that may emerge from these diagnoses. Of course, Prairie St. John's is open 24 hours a day, 7 days a week for needs assessment. Always remember, just because you go to a psychiatric facility for an assessment doesn't mean you'll be admitted there, but they can tell you other resources that may be available to someone who is in crisis if admitting is not necessary. Always encourage an assessment with a mental health professional. They'll be able to figure out pretty quickly what an older adult is struggling with and help them get started with therapy and medication. Of course, testing to rule out other concerns, social support, and encouragement. Always remember to talk with an older adult and show them your empathy, show them that you care. Sometimes we have the best intentions, but we come across in a way that may seem demeaning, or it may seem like we're being critical over someone's thought, mood, or behaviors. Inviting someone to social activities, going out for a walk, doing things to show that you're going to be present in their life, and reminding him or her that the symptoms can be managed and they don't need to live the way that they've been living. A little bit over time. Any questions? Thank you.
Oh, we have a question.
Okay.
One quick question. What are some ways that you can treat delirium?
Treating delirium is most likely going to be done in a hospital setting. The point of bringing up delirium is so that you understand the symptoms and the sudden onset, so that you can identify it really quickly. A lot of times it will be medications that will help get the person out of that state of delirium.
Thank you.
Also, you're on mute. Good morning. I have a question, and Del's like also.
Yeah.
If a person drinks or uses other substances because they're isolated, how can that be solved?
Telling them that you care, that you're concerned about the amount of alcohol that they're using. Let them know of the risks of using this alcohol. When someone's experiencing depression, the depressive thoughts keep them isolated. If you're using alcohol, that's going to keep you even more isolated. You don't want to see people when you've been drinking or feeling depressed. So just encouraging them to get out of the home can be a good first step. Any other questions?
Thank you, Gina. That was a lot of information in a short amount of time. That was wonderful. go ahead at your sites and take a 15-minute break, and we will be back then at 10:20 Central Time to reconnect and continue with our conversation. And Beth will be talking to us about substance abuse and use at that time. So take your break. Thanks.
Okay, we're unmuted.
All right, welcome back, everyone. We will continue, and I mentioned earlier, our second speaker is Beth. Beth Brantner will be speaking about substance use in North Dakota, and so take it away, Beth.
Thank you. So, my name is Beth, and I am a counselor at Prairie St. John's. I'm a licensed addiction counselor as well as a licensed professional clinical counselor in the state. I actually have 3 degrees from this college. My trajectory kind of changed. I was in the first class for animal health technology for veterinary technicians, got in a car accident, was intended to be a veterinarian, so I had to kind of rethink things and ended up going back to get my master's in counseling here. Anyhow, so I'm going to be talking about substance use in North Dakota. It's kind of an overall view. The kind of the agenda is going to be looking at trends. We're going to spend time on that. Intervention, spend some time on that. Treatment a little bit. Gina kind of covered stuff, so that's all good. And then some prevention. The information that I got that I'm sharing with you today it's all in the very last 2 slides for my resources. There's some really good information out there as I was preparing for this presentation. So, state trends in North Dakota, and I thought we'd start for the good stuff first, okay? And some of this is well known and some of it is rather surprising. So this one is rather nice. We are the 4th lowest state in overdose deaths per capita. We are also the 4th lowest for drug use or drug addiction. High school students who drank at least once in the last 30 days, 10 years ago, it was almost half. And now in 2017, it's just under 30%. That's kind of a nice change. The marijuana use in kids, of course, that's what the illicit substance that kids use the most. It hasn't really been much of a statistical change, okay? Percentage of kids who are offered, sold, or got something illegal on school grounds has decreased. That one was a nice change too, I thought, from 18% down to 12%. So we have some nice things going for us, but we have some not so good. And some of this is in the news. So, yep, we are the drunkest state in the country. We have that dubious distinction. I did not know, though, that about 1/4 of our adults drink excessively. And what that means is that for women, it's 8 or more drinks per week. For men, it's 15 or more. And it's a little bit surprising where the, I think it was SAMHSA, Gina shared the SAMHSA stats for older people is not over 7, for women, not over 7 per week. So it's just down a tad, but it's still heavy drinking. This one, 1/3 of our people are binge drinking, admitting to binge drinking in the last month. Binge drinking is considered it's some differences between males and females, and it has to do with our anatomy or biology. But a binge drinking for women, it's considered 4 or more drinks within a couple of hours. For men, it's 5 or more drinks within a couple of hours. So it's at one setting, just a couple of hours. This one is also a little bit staggering. We have the most bars in the nation per capita, okay? Here's how it goes. We have 1 bar for every little bit over 1,600 people, okay? There's 1 liquor license in our state for 498 people per state, okay? In comparison, okay, state of Virginia, they have 1 bar for every 64,700 people. These are big, it's like, wow. Underage drinking costs nearly $160 million yearly. I don't have a concept of $160 million. I just know that's a lot of money every year. And that's just for our underage kids, people 21 and under. If you look at the adult excessive drinking, what it costs our state, it's $488 million. That was in 2010. That was the most recent stat I could pick up. We're now 8 years ahead. I'm guessing it's increased. This one is a concern for me. High school kids who think binge drinking, now we know what binge drinking is. High school kids who think binge drinking is okay or it's not harmful 1 to 2 times per weekend, okay? That's a lot of kids, right? That's almost 70%. The other concern that I have that maybe a lot of folks have picked up on is that there is a change in perception where people really think that marijuana, cannabis, weed, Mary Jane, whatever we want to call it, that it's harmless and it is not addictive, that it's an herb, and that's not correct. I got some information from the North Dakota colleges. It's like let's look at our population a bit. The colleges do a survey, it's a voluntary survey every 2 years. So I pulled up some information. We don't have to go through all of it, but I thought it was sort of interesting. So for example, drinks per week that college kids are admitting to, in 2012, it was 5.15 a week. And 2016, which is the most recent, it's 4.5. This one is good. Believe alcohol is necessary to have a good time. So in 2012, it was just under 12% people. 2016, we're just under 6%. Yay, we're making some nice gains. Driving under the influence, this is a concern. So in 2012, what the college students were saying is 11.8% said that they are doing it. In 2016, we've gone up just over 18%. Okay. 5 or more drinks per setting in the past 2 weeks. The ones who admitted to it in 2012, it was just over half. 2016, 42.5. A little bit of a decrease. Some other ones. Doing something they later regretted. Okay, that's under the influence of drugs or alcohol. It's over a third. In 2012, 2016, it's not a big change. Okay, statistically, we're not making a big difference there. The cannabis use within the past month, that's staying fairly consistent. The one that I wanted, as a mom who has helped pay for college, I went back to college as a little older than an average student, performed poorly on a test or project due to their usage, okay? College is expensive. And if our students are not doing as well as they could be, this is a concern, right? So if that ends up accumulating, people get poor grades, people need to repeat the class, they need to drop out, or whatever, this can add up. Oh, this has turned. I wonder if they can still see me because it turned up here. Okay. Hopefully, they can still see me. The next slide is about, it's a little bit more some adult statistics. And so for example, 2013 to 2014, only 1.6% of our adults reported illicit drug abuse or dependence. As we probably all guessed, marijuana is the most commonly used illicit drug. Adults 26 or over, okay? This one is sort of a nice, it's low. It's 4% of our adults that are 26 or older are saying they use that. 3% of adults 26 or older are saying that they are using opiates. Those are the pain medications that we have this opiate crisis going on. But Only 3% of them are saying they're using it for non-medical dose working relievers. Okay, let's see. So other than marijuana, 2.3% of the North Dakota adults, 26 or over, are saying that they're using. Here are two that are important. However, we have one prison in North Dakota. The estimate is 75% of the inmates have substance use disorder. Okay? It's expensive. The other thing I wanted to show is that overdose deaths. Now, we talk about the opiate crisis. It's in the news fairly often. But the best statistics I could find, the most recent or compared, was in 2013, there were 20 overdose deaths in North Dakota. In 2016, 68. Okay? Okay, but I want to just do a little bit of a thought. Over 43% of the fatal crashes in North Dakota, car accidents, are alcohol related. Okay? 41% of domestic violence cases in North Dakota, new ones, are alcohol related. In North Dakota, every 11 hours, there's an alcohol-related motor vehicle accident. And in North Dakota, every 7 days, there is a death. That's a motor vehicle related, a death from a motor vehicle accident that's alcohol related. Every 7 days, somebody dies. Okay, so that's more like 52 people are just dying on the roads per year. And if you remember, I went to the overdose deaths, 2016, it was 68. And I'm not trying to minimize the opiate crisis, but I'm trying to emphasize that we have an alcohol crisis in this state and we don't talk about it. Okay, if that makes sense. So I'm kind of going to be focusing on alcohol. With kids, it's the most widely used drug, right? North Dakota, we're also ranked as #1 in the binge drinking for our kids, 12 to 20. That's not a statistic that I'm particularly proud of. In the most recent, this is based, some of these stats are from this, it's a youth risk behavior survey. 14.5% of the high school students had their first drink at age 13. Here's why I'm concerned. We know that the earlier someone starts using mind-altering chemicals, alcohol, cannabis, the higher the likelihood that they will end up with addiction. This is pretty early. So 13, that means they're 12 and stuff. Now we're talking like 6th grade, 7th grade. I gave you the statistic already about underage drinking. Here's another one, parents. 16.5% of our high school students rode in a vehicle where the driver was drinking. Okay? That's 1 out of 6 of our high school students was in a vehicle with someone drinking in the past month. Okay. All right, let me make sure I can do this. There's a video I want people to see. One, two. Okay. You know what? She's going to get some help. I'm going to move on to the next video or the next one slide. We'll come back. So I had these all pre-loaded, and I'm not sure what I'm doing incorrectly. Oh, never mind. Here's my helper. So I pre-loaded this. I saved it in a tab, and I used that one. Yeah.
Okay.
It's the other one. There we go.
Okay. And from that point on, from the beginning?
Yes, beginning.
Another top ranking for North Dakota, but this time it's not a #1 spot to be proud of. A new government study says the state has the highest rate of binge drinking in the nation.
The driver was determined to have a blood alcohol content of 0.25. I never ever considered something like this would affect my life.
But police say they've seen a rise in the blood alcohol content of the drivers they pull over. On average, a person will drive 60 times while intoxicated before their first arrest.
The 4 hockey players are suspended following an apparent alcohol-fueled initiation party for freshmen last weekend.
We saw several students who were so drunk they could barely walk. One student who was passed out was being dragged up the stairs, and another one vomited in the hallway.
In possession, walking on the streets with beer hands.
Are you mad?
No, not angry, no. I mean, we broke the law.
They didn't really care what the rules were, even if it meant getting a $300 ticket.
It's Spring Fest. Everyone is like this. I mean, you have to really basically be rolling on the ground to get really in trouble, and
it's kind of like our last hoorah.
Just before the accident, he was at 2 bars and had more than 10 drinks. Wyatt Klein was driving the blue pickup, the Deutscher family the silver Subaru.
Is this for real yet, or am I in this bad dream? I keep asking, and I'm saying no, it is not a dream, it is reality.
Thank you. I have one at the end of this too. First time I saw that clip, it affected me. North Dakota has wonderful, we have great values, but the extent, the one about how they estimate that someone has driven drunk 60 times before they're stopped. That's a lot of people. So we're going to kind of go through. At the end, we'll do some questions. So if you have some based on that clip, you write them down. But so let's look at how do you know what might be some indicators of usage problems. Okay. And the next few slides have quite a bit written on them, but I wanted to make sure that you had it so that you could refer to them later. One of the things as addiction counselors, what we look at is it's called an increase in tolerance. And that is where a body needs more and more to get the same effect. Not everybody has that, okay? And there's sort of a belief with a lot of people that, well, just because you get older, that you can drink more, and that's perfectly reasonable and understanding, okay? Or understandable, and it's a concern. People that can't stop, they have lost time. Part of it would be, there's a curious thing with alcohol. When you drink so much, there's a thing that can happen, it's called a blackout. People can walk, they can talk, they can go to work, they can drive. They lose time. There's no memory. It's like the chip was never inserted. Even under hypnosis, you can't get it back. It can be a couple minutes. I've met people who have lost a few weeks and they don't even know what state they're in when they kind of come back. But people can't account for time, right? An impact in different life areas, social, work, school, spiritual, your value system, your emotions, your leisure time. They keep using despite their problems. Nope, it wasn't a problem. It was just that rotten police officer. Rotten cop is what I'd hear more. Or it was my boss, he's just an idiot. It's always somebody else's fault. Can't recognize it. Addiction is a brain disease, and part of it is your frontal cortex is not, it kind of keeps people from seeing reality. So we call it a disease of denial, but that's why. Withdrawal. This I want people to know, because I don't think people know this very well. We hear about withdrawal. We hear about opiate withdrawal and how horrible it is. It's like the worst influenza times 10 that you've ever had, where your hair and your bones hurt. That's withdrawal, but it doesn't, it's not going to kill you. Alcohol withdrawal can. People can die from alcohol withdrawal if they've been drinking routinely quite a bit. And so at Prairie St. John's, that is one place where people can go to have nurses, medication, so that you can safely get through that alcohol withdrawal. You can go to emergency rooms. I know there's a detox in Fargo. It's more of a social detox, but people are watching you. But people don't know that, and I know people who are now dead because they decided to just quit and they end up passing away. A lot of lies, broken promises, legal issues, as you can tell, dangerous behaviors, impulsivity, I have a hard time with that word sometimes, poor judgment. Again, frontal cortex is not working very well. And so that's where that higher functioning takes place. Some more signs. Dysfunctional emotional response. What we mean by that is if you say you're trying to talk to somebody about, you're concerned about their drinking or their usage, and they totally blow up on you. Okay? A big overreaction, that's a clue. Or, I see this with teenagers quite a bit, especially with marijuana. It's their whole life. They just love weed, and whatever topic you're talking about, pretty soon they weave that into the topic. It's just there, okay? Preoccupation, that means that you're kind of thinking about it. It's hard to just put it away and function on work, okay, or function on other things. That altered look at positive use, again, that's that frontal cortex is not working very well, and you just focus on the fun stuff. And sometimes people forget that drug and alcohol use in the beginning, there is fun associated with it, right? But as it progresses, things get worse. Kind of went through some of these. The problems are something else. Gina talked about anxiety with adults or older folks and stuff, emotional pain. We see that with alcohol or with drug use. You can see that increased anxiety and where people have a little more difficulty handling stress, enough said there. Few little different ones just for kids, because I just want people to be aware. I'm guessing that we have people who are parents that are watching this, and parents are often the last ones to kind of recognize it, because we want to believe the best in our children, in our teens, right? And so sometimes it's hard, but if you see some of these warning signs in your adolescent, or sometimes in your 12-year-old, 10-year-old, 9-year-old, it means that it's a signal that you need to start figuring out what's going on, okay? Poor problem solving, memory problems, coordination where they're coming home and they got bruises and oh, I just fell. Withdrawing from the family, they're not participating. They are in the basement, in their room, or off with their friends. Families have certain rules, right? Everybody pitches in, it's your turn to do the dishes, or, we're all home for supper. We all have them. They're not really participating in them, they're violating them. Not following through on what they need to do. Sometimes they can become abusive verbally, physically. It might be verbally, it might be just calling parents offensive words. And start out there. School performance decreased. It's easier to keep on top of that nowadays because you can get into your kids' through the internet and check and see. I don't know if that's with all school systems. I know in Fargo you can. Change of friends, poor hygiene, bloodshot glassy eyes, Visine or eye drops. If you see them having eye drops around, okay, a lot of times people who are smoking weed, they get red eyes. So you got this eye drop thing they're always, if you're going through a lot of Visine, you might want to question why. I talked about the injuries, increase or decrease in appetite. If you're smoking weed, typically people get the munchies and they start eating more, not necessarily healthy, but eating more. Sometimes when people are drinking, they're not eating so much because they're getting the alcohol, or the calories are coming from that. If they're using speed, okay, type things, people don't eat. They don't sleep. If you are missing valuables in your home, this is a good indication, and oftentimes it's not something that you see all the time. It might be great grandma's wedding ring that you keep in your jewelry drawer and you look at it once a year. Okay, kids are smart. They probably, if they're taking money from you, it isn't all of it, they'll take some of it. So then you're going, oh, well, maybe I spent it someplace, right? Can't focus, poor attention span, can't learn. So let's just talk a little bit about what addiction is. When I talk to family members and when I talk to people who their drug or alcohol usage has affected them, we go through a whole bunch of these. I go, you know what, this is a disease. In the mid-1950s, I think it was 1956, don't quote me though, the American Medical Association said it's a disease, which means it has symptoms, it has signs, it has progression, but they weren't really sure what organ. If you have asthma, it's a disease of your lungs. If you have diabetes, it's a disease of your pancreas. They weren't really sure. In 2011, it's called ASAM, the American Society of Addiction Medicine, said it's clearly a brain disease. And I told you about, there's two parts of the brain. One part is the frontal cortex. The other part has to do with the pleasure part. So if it's a brain disease, that means it's a no-fault disease, okay? And I'll be talking to somebody and say, so, and they'll go, they'll do a stop, blink. So it's not my fault I'm an addict. It's not my fault I'm an alcoholic. And I'll go, no. But it is your responsibility to manage it daily. They're like, oh, okay. It's chronic. Once you got it, you got it. Kind of like, it's like pickles, right? You go from a cucumber, put it in brine, it turns into a pickle. Once it's a pickle, it's a pickle. We can't turn it back into being a cucumber. So that one seems to, people kind of go, oh, got that too. Mind, body, and spirit, that's sort of a 12-step phrase, but affects It affects how you think, it affects you physically, it affects who you are in your value system. Family disease, and that little poster kind of indicates to that. What the stats tell us is that for every one person with an addiction, 15 to 18 other people are significantly affected. In our country, 2/3 of the families in our country have been touched by addiction. So again, going back to that chronic thing, it has no cure, but there are solutions. We'll get to that. So, this would be kind of aimed at if you care about somebody who has an addiction, or you're concerned about their usage, what can you do? Attending things like this is great. Getting some education, starting to understand it. Taking care of yourself, keeping yourself safe. Keep your valuables safe, keep your money safe, keep your bank accounts, your investments, all that information, keep it safe. Don't enable. Enabling means that you do for people what they should and could do for themselves. It keeps the usage going. And people will enable, a person doesn't have to necessarily move into, like cross that line into addiction, but they might be using or drinking significantly, and family members will still kind of enable, and that keeps it going. Get support for yourself, take care of yourself. It's sort of like dealing with a family member who has dementia, right? We understand how stressful that is to people. Dealing with people who are harmfully involved with drugs or alcohol is very stressful, and it's family members need to take care of themselves. Find hope. This is really important. Things can get better, okay? Get involved. We'll talk about that down the road. Fight the stigma and shame. We're going to talk about that too. There's kind of a belief that it's someone's fault that they are an addict or an alcoholic. I have talked to legislators and they've shared with me that that's what the constituents believe. And I'm like, no, it's this brain disease. I go into all this biological stuff. And they're going, no. It's the person's fault because it's when they first picked up that first drink, that first joint, that first pill. In my groups that I do, and I do a bunch of them, I ask, when did people first start using? And it's almost always someplace between 12 and 16. And so that notion of holding somebody accountable for something they did when they were 12 to 16, I don't buy that. Okay. Some of the interventions that can happen, all right? So somebody, Gina showed a picture of North Dakota with the 8 different human services centers, right? They have 8 different sections. They have people there that can do an assessment and can figure out what kind of treatment, if there is something needed. You can do that at human service centers. You can do that at chemical dependency treatment centers. They're across the state. You can go to places like Prairie St. John's, where there's a free assessment just to kind of figure out what's going on, and then they can set you up with an addiction assessment if that's what's needed. People, you can use emergency services. So I talked to you about how alcohol withdrawal can be deadly. But also there's things like overdose, right? You can have alcohol poisoning, and it's a central nervous depressant. People can die from that and quit breathing. People can get in car accidents, emergency services, right? People can overdose on other opiates, right? People sometimes think that with methamphetamine you can overdose and die, but I've talked to some people who have had heart attacks and they were 30s and from their meth use. We talked about detox a little bit already. Formal interventions, people have watched the intervention show on TV. If you are thinking of doing something like that, get help from a professional. Things can go wrong really quickly. And so it's an option, but get help. You can go to a counselor, getting counseling services. There is medication-assisted treatment. And depending on the chemical that is used, what it is, it's where the person can take medications that will help with the cravings. Some will help for alcohol, for example. If you drink, you get really sick, violently sick. Some, it will take away the high. So even if you use, you just don't get so high. Support meetings, peer support, AA, NA, SMART, Al-Anon. That's for people who have been affected by someone else's usage. They're free. You can tell them your name is Daisy Duck. It doesn't matter. There can be legal interventions. Here's an idea that a lot of people haven't thought about. So let's say that you have a loved one or somebody you know, they are intoxicated or high and they get in the car. You can notify law enforcement. Let them know what you know. Here's what they're driving, here's a license plate, here's what they're using, here's why I'm concerned, they went in this direction. That would be a legal intervention. A lot of times people think that getting in trouble legally is a bad thing. From my point of view, it's a very good thing, okay? You can blow off teachers, parents, employers. You can't blow off judges in the legal system for an extended period of time. Gina went through this actually already, so I'm just going to highlight the one part at the top, because this is kind of cool, right? So in the 50 states, we come up 5th highest with the per capita treatment facilities, chemical dependency treatment facilities. Didn't know. Now, we have a little bit of issues because it's so rural, and it is there's a lot of rural area here. But on the other hand, we got a lot of places to go. This is kind of new. A lot of folks don't know about it. I just wanted to bring it up. So there's a thing in North Dakota. It's a SUD means substance use disorder voucher, and it says the requirements in here. But what it is that people can get treatment if they don't have insurance. You can also get treatment at the human service centers as well. Okay, so there are some requirements. So I put them in here so people would have that in hand. But I know at Prairie we utilize it. Okay? And this is a good thing. In North Dakota, how am I doing the time? Okay. In North Dakota, there are a couple of programs that it's good to know. So for example, North Dakota's on the ball in a lot of ways, okay? So there's a substance use prevention and treatment block grant. That's for all the states get that. But here's what North Dakota, how the Behavioral Health Division utilizes it. They are looking at, they utilize to plan, implement, and evaluate the care related to treatment, okay? So what they're doing is trying to make sure that when people need treatment, they are getting quality treatment, right? Facilities need to be licensed, and it's rather rigorous to get that licensure. Addiction treatment or addiction counselors have to be licensed. There's a lot you have to do to get that. That's good. There's another grant that North Dakota got. This is fairly new. It's called Free Through Recovery. Do you remember when I said that 75% of the inmates have a substance use disorder? Okay, so this is pretty new. But it's really to help people that are involved in the criminal justice system, right? And some of the stuff that they do is they do care coordination. And what that does, it's kind of connect, refer, collaborate with people. You're working with people who can help you do that. And it can be for housing, it can be for food, it can be for medical, it can be for education. It's, recovery services, people there to help you figure out things like housing. If you are homeless, it's really hard to get your life going, right? So housing, education, again, parenting, and then also some peer support. And that's really kind of a new movement in our country. It's been on the East Coast longer than it's been up in our neck of the woods. But it's about having people who have are in solid recovery, so they've been there, and they get some extra training, and they're there for support. Okay? They're there, it's like, here's how I've handled it. Somebody who gets it, right? That's a big deal. Prevention. So there's a story, maybe some of you have heard it. It was sort of an illustration that I read about prevention. And it goes like this. There was this guy who was fishing on the side of a river, kind of a fast-moving river. And pretty soon, there are people. They're like struggling, flowing down across them. Okay, so he's wading out and he's trying to keep pulling them in, and more people keep going through, and he can't save them all. And he's trying and trying, he's getting exhausted, and it's getting worse and worse. More people are going and drowning. He goes up the riverbank, walks upriver, comes to the bridge, and there's a hole in the bridge. And fixing the hole is like prevention. I think it needs to go one step further. It needs to go so that the people that are walking and falling in the hole are involved before they even touch the bridge, so that they have some understanding of what's ahead of them. What am I looking for? I need to know the dangers. So it goes a little bit more. And that, I think, is that part of that culture thing that we'll be talking about. So prevention is, what can you do? I used to work with this one really awesome counselor, but kind of a gentle giant type of guy. And he would always say, change begins with me. And what he meant by that is no matter what he wanted to change, whether it's something in his family or something in his workplace or even something larger, it started with him. And I've always remembered that. There we go. So there are evidence-based strategies for targeting underage drinking, right? And I believe that's where we really need to start. And with something as evidence-based, that means it's gone through all kinds of studies and is proven to be cost-effective, and it works. And here's the deal. For every $1 put into prevention, it saves 68. That's kind of a staggering amount. Okay. So we're going to kind of go through these 4 different areas and see what you think, if they make sense. And I was glad to hear that law enforcement is probably listening to some of this, because I'm guessing that they'll go, yes, right? So part of it is, I already talked about how many bars and how many liquor licenses there are in our state. It's a lot, right? It's very easy to get alcohol, okay? So part of it is making sure that if there are events, they require permits that where alcohol is being served, okay? I think that's followed pretty well in the larger communities, not so much in some of the smaller communities from what I've been told. Making sure ID is being checked. And it isn't just a glance on something that looks really sketchy and saying, okay, it's like really checking to make sure that ID is valid. Compliance checks of retailers, right? And that's making sure they are checking the ID. They're doing what they need to do. Limiting the outlets. It's a good idea. I don't know how to do that. Luckily, it's not I think you have to be a politician and really look at some of that. But we have an awful lot of availability all over. Some of our small towns, right? 2 churches, 2 bars, gas station. Having the police, like going through stores, just walking through sometimes. And then here, it sounds good, but they also are very busy doing all their other stuff. And so, it might be easy for us to say, hard to put in practice. Responsible beverage service training, I don't know if you guys have heard about it, but what it is, it's a good thing. It's that servers have to do some training so that they recognize the signs of somebody is having too much. How do you handle it? How do you say no? You quit serving them. Okay? Okay. High social access. Talked about permits. Restrict the age of alcohol servers. I don't know if you know this, but in North Dakota, you can serve alcohol if you're 19, as long as you have a 21-year-old supervising you. Okay? But, okay, so if you take this a couple steps further, 19-year-old serving people who are a little older, but still kind of peers, might even know them, and then you have a 20-year-old, if they're just 21s, I mean, you have some age kind of possible issues there. So maybe bumping that server age up. But then, might have some issues with, we can't find enough people to be employed the way it is. I mean, these aren't simple, easy fixes, but it's things to consider. Team parties in motels, hotels, apartments. Think about it. We got spring coming, kind of here, and we have prom. And, you know, we all have heard of after parties where they've been able to get hotel rooms or suites and big parties and that kind of thing, away from mom and dad. Shoulder tap program, and what that is, it's where law enforcement uses minors as kind of decoys, and there are pros and cons for that, and I've heard a number of them. This is evidence-based. Remember, these aren't best ideas. These are all the evidence-based ones that demonstrate that they're effective. Social host liability law. So what that is, it is liability can be held on you. So if you have a barbecue and you invite a whole bunch of people over and you have a keg or a bar or whatever, and somebody leaves there and they get in an accident, you can be held to be liable. It's for adults as well as for kids. Texting tip line, and what that is so that people can just text and notify. There's something where you could, like notify law enforcement there's something going on. Okay, so I saw this picture on Facebook when I was getting ready to do this. I'm like, I have to use this picture. So I don't know if you can see it so well, but it's a catnip garden, right? And so then all these cats have shown up and they're just like out, right? My point is, when things are made available, if there's easy access, people will go. People, whether it's catnip, whether it's meth, whether it's opiates, or whether it's alcohol or weed. Okay? So I just thought it was a good one. Enforcement. Again, this is those, their norm. These are the evidence-based. So impose appropriate penalties, strengthen prosecution. So what happens, so let's say an officer they're stopping people, they end up, charging, they might be going into jail, right? And then there are deals cut, the consequences get reduced or wiped off. Or I hear about that every week, probably every other day I hear about things that, well, they're not gonna do anything about it. Okay? And I don't know why that happens. But that's something. The teen party ordinance, loud party ordinance, so that can be really enforced better. Adjudication and sanctioning. Adjudication means a formal judgment on a disputed matter. Sanctioning is penalties for disobeying the law. So having some teeth. Community norms, okay? And this is part of it. At that clip, that clip that we watched, it talked about how we have this culture of drinking in this state. And these are some ways to address it. So, like the alcohol advertising, the sales, really starting to corral that so it's not so easy, it's not so ubiquitous. A media campaign to start promoting, start giving this information out so people know. School and college worksite policies. I know here at NDSU that they've made some really nice gains in reducing the consequences that students experience. Okay, so it might be, here's an example, this was a few years ago. It might be that they're still drinking quite a bit, but they're having designated drivers. Okay, so there are some changes that are made, but part of it is like, what else can we do? Because once again, change begins with me, right? Just looking at the time, sorry. So on that clip, it had a thing about parents lead, and here's, I wanted to include in here so you kind of know, and they've got a really nice website you can go to, but it's about listen, educating, asking, and discussing, right? The belief is when children are younger, parents have the most influence on our children, right? But again, part of it is what we say and what we do has to match up. So if you're saying, oh, you know, drinking's bad, or you're trying to give this message like, yeah, but then you're coming home going, man, I had a bad day, I need a beer, you know? And so you deal with, if they see you, that's how you deal with stress. That's how you deal with a flat tire. I mean, normal things that happen. And the way you deal with it is by putting other chemicals in your body. Their kids are going to watch what you do much more than what you say. But this Parents Lead, it's a good website. I have it on here. Suggest that you, if you're interested, take a look at it. There's also a positive community norm campaign, and that's through the Center for Disease Control. But it's really about trying to create stable, nurturing, safe relationships, environments, right? We have a huge stigma with addiction. A lot of blame. There's so much blame just in regular course of talking, and that keeps people from getting help. It keeps people from talking. It keeps people from saying anything. You know, it might be, oh, not my kid, or I'm not telling grandma, I'm not telling anybody what's going on. We just keep it in the family, we deal what we have in the family, it doesn't leave. And that just keeps increasing. Then we go generation to generation of problems. Okay? Let's see. I have one more video I want to show, and then we'll just have, we're kind of running out of time too. Oh, here it is. I'm like, I can see it on here, but I can't see it on here.
Yeah, you have to. This is an extended desktop, so you have to move the mouse over basically.
Oh. It's the it's the anonymous people one.
Whether we want to admit this or not, this is our Black Plague.
There's 25 million people that suffer from this illness.
We have an epidemic.
It's a national crisis that untreated addiction cost our economy over $550 billion last year.
It is disgraceful that we have done so little about it thus far.
Once you're an addict, you're that thing that they have to hide.
So many people think of addicts as homeless people living under bridges.
The media is difficult for us to battle against because the negative news about addiction is dramatic.
You know what we in the media do? We wink it. We Snoop Dogg it. Hey, oh yeah, they're stoned, that's fine.
If everyone thinks of alcoholism and addiction as a negative thing, no one's going to want to go get help.
As a culture, we are still very rooted in just say no.
drugs are menacing our society.
We were going to try to incarcerate our way out of the addiction problem.
Our jails are full of addicts and alcoholics. They're all pulled up in one spot.
When you're caught, you will do time.
Recovery is what you need, not prison. Hello?
Alcoholism has too long been a taboo subject.
The shame and secrecy are just as deadly as the disease itself.
Our numbers are unbelievably strong, but yet we have no voice.
We know about every issue out there, but people don't know how important the issue of recovery is.
As a person in long-term recovery from an illness that has no cure, but an illness that has a solution.
If we could ever tap those 20 million people in long-term recovery, you change this overnight.
Now it's my turn to teach you that recovery works.
History's on our side. History will show one day who and what we are. So I say we make history.
Voices are out there. We have to find and open the hearts. And I think those hearts want to be open.
I refuse to feel ashamed of who I am. I most certainly will not be embarrassed that I'm an addict. I'm going to tell whoever I damn well want to.
There's a lot of us. Everyone knows somebody.
Questions?
Okay, we have a question.
Okay.
Hi. How much of an effort do you see substance abuse treatment turning towards getting to the root of the issues of why each individual might use a substance? You know, I see a lot of, I have a lot of issue with lengthy programs that treat it like it's a party or that it's someone who simply is making poor choices. You know, I'm finding more and more with my clients that the issue actually is that they're drinking or they're using drugs for a reason. More important than health, more important than really more important than anything else. And so, do you see that in substance treatment that we're moving towards moving in that direction at all, towards the root cause of substance use rather than treating it as something?
Okay. So what the statistics tell us is that 50 to 75% of the people with a substance use disorder also have a diagnosable mental illness. Most often, like an anxiety kind of thing or a mood disorder. We are getting better at, we need to treat them both at the same time, right? But I think what you're also alluding to is, it's kind of like like if the addiction is the tree that you see, it's like what's in the roots, right? The pain. You know, there's a lot of abuse, there's a lot of loss, there's a lot of grieving that a lot of these folks experience, right? And is that what you're kind of talking to, right? But part of go ahead, I'm sorry.
My clients are self-medicating.
They're self-medicating, yes. So, and sometimes, so someone might be depressed, right? And they start self-medicating, and it's effective in the short term, but over the long term, it makes your depression worse. If you're using alcohol, again, alcohol is a central nervous system depressant, so it's kind of like pouring gas on the fire. It also, if they are taking medications for their mental health or mental illness, and they're still using, then but they don't tell the doctor what, extent of their using, to really minimize it. And then the meds don't work, and they're frustrated. So what I'm trying to say is we really need to address both of them at the same time. Okay? And we're getting a lot better at that. As a profession, I believe. As a whole behavioral health profession, recognizing all of that. Anything else? When I duck, I'm just looking at the clock. Any other questions? Okay. thank you for giving me the chance to share some of this information. We have one more to go, and we're almost perfectly on time. Miracle. And I'll get out of this. It should be really good.
So,
It was on the desktop and it's not through.
okay, it's, yeah.
Oh, there it is. Okay.
You'll have to basically remove it.
So it's the emotional stress. There.
Yeah. Started. So you'll see if you have notes there.
Sure. Okay, sounds good. Okay, we're just gonna jump right into the last presentation. My name is Monica McConkey. I'm the Director of Business Development at Prairie St. John's. And as Kim introduced me earlier, I have been in behavioral health for a lot of years, primarily in Minnesota in rural areas. So that paired with growing up on a farm, I do have a lot of passion and emotion actually that I feel every time I read one of these new newspaper articles or stories in the media talking about the farm stress issue and suicide rates increasing among farmers and just all of the struggles that farm families are dealing with right now. So I have a lot to say and not a lot of time to say it, so we're just going to get through this information. So this is me like 30 years ago when I was Minnesota milking Shorthorn Queen. And when I look at this picture, I just laugh, and I told Kim the title for this picture should be Still Making Poor Shoe Choices after all of these years. So I grew up on a small grains farm in northwestern Minnesota. This is the family today. And my dad farms with my brother, and actually just in February, my nephew joined the operation. So there's some transitioning going on, and that raises, enough stressors just all by itself. And then when you pair it with the things happening in today's farm economy, it just makes it even more interesting. So just really briefly, in the next 35 minutes, I'm going to talk about stressors. People might be wondering why, what's going on with farmers right now. We often see the big equipment and the nice trucks and the homes and think about all that land, and sometimes it's hard to really understand why they're under stress. What's the problem? There seems to be some funds and lifestyle that are working in their favor. Then we'll also just talk about specific warning signs that may be a lead-in that there's something going on in the way of a behavioral health crisis. And we'll talk just really briefly about ways that we can maybe not confront, that's not the word I want, but express our concern for an individual and help them access services. So just running through stress on the farm. There are, living in North Dakota, whether people farm or not, you just know this, there's a lot of uncontrollable factors for farmers, and being dependent on the weather for your livelihood is not an easy thing. To this day, I still watch the West because the weather always came from west to east, and I watch the clouds and weather reports, and my kids tease me because I'm on my storm app, and I don't farm, but it's just really ingrained that the weather kind of controls your life when you're farming. So other uncontrollable factors are, of course, the commodity markets, which we've seen really take a tumble, and highest interest rates. The land rents that farmers are paying obviously are not coming down at the same rate as commodity prices, and chemicals and and fuel and all of that. Those prices are staying high. Well, what we're getting for our crops and milk is not. So other stressful factors on the farm are illness and injury. We all know farming is a very dangerous occupation. I'm sure it's very common for all of us to have known or seen farmers with missing fingers, missing arms, missing hands. It's out there, it's common. People die in farm accidents fairly routinely, kids and adults. Farmers are also isolated. Farm families are out on the ranch, out on the farm, often without regular contact with other people if they're not working outside the home. There's competition for land, which has created some very interesting dynamics among farm neighbors. Sometimes they are even related, and back years ago there was really more of a collaborative approach when it came to farming and supporting each other. That just doesn't exist anymore because of the competition for often land. And sadly enough, whether it's spoken or not, farmers kind of wait and watch for their opportunity to come in and scoop up more acres. There's an increased need for competency. Things are going digital. There's computers that run your machines. The amount of information that farmers are expected to know about chemicals and agriculture, crops, animals is just growing, and it's not simply about hard work anymore. There are very irregular and uncertain times of income, and that ties in with the work hours as well, depending on the time of day. I know I talked to my parents and my brother, and there are days and days and days with very, very little sleep, or they'll stop the tractor at the end of the row and put the feet up on the steering wheel and catch a half an hour of sleep before they're back at it. So that you can only do that kind of thing for so long before it really takes a toll on your functioning. And then there's barriers to help, and we will be talking about these later in the presentation as well. So I'm just going to jump right in to some common behavioral health diagnoses. And really in the previous two presentations, these were covered really well. But just some things to be aware of that we commonly see with farming and ranching families. A lot of anxiety, obviously, about things that are outside of their control. A lot of depression, suicide, and we'll talk more about that. And then things like adjustment disorders, and then our substance use disorders that Beth talked about. So with anxiety, you'll see a lot of fatigue, and it can be caused by just great periods of restlessness, mind racing. There will be hypervigilance, disruptive thoughts, excessive worry. I remember when I first learned, I knew there was always stress, of course, on the farm, but I remember when I first realized that my dad was struggling with anxiety in a clinical sense. I just overheard him talking to a family friend, and he talked about how it was really panic attacks is what was happening to him, but he couldn't sleep at night and would wake up and just feel the need to actually run and get a lot of energy out. And my dad never even wore tennis shoes. He still to this day only wears cowboy boots. So the picture of him like running, he was frantic because of the internal anxiety that he was feeling. So it's just important to be aware that if you're seeing some of these things, that it could be related to a behavioral health diagnosis. And I just have to ask you, when you guys were up here, where did you look? Camera, audience? Camera, okay. Because I feel like I'm not sure where to look. Okay. Other signs, depression, it's that feeling of hopelessness. There can be a lot of guilt associated with potentially being faced with losing the farm. So you have a farm that's been in your family for 100, 115 years, and it's on your watch that farm is going to be lost. So that is a great weight to carry. So you may see loss of appetite with depression, a lack of ability to concentrate, and it's even, you know, those physical changes are not maintaining weight, or there's a weight increase. It's really looking at changes from baseline functioning that are going to tip you off that there's some problems happening. And then with adjustment disorder, that is really defined as a stress-related condition that it's experienced more stress than normal, quote unquote. So it's a common diagnosis, but often leads back into anxiety or depression. I do want to back up just a minute and talk a little bit about kids on the farm. And I think we often overlook the amount of stress that the kids are dealing with in those situations. And I can just talk about from personal experience, the mistakes you make when you're a kid helping on a farm are usually hold much greater consequences than mistakes kids would normally make, like working at a store in town or a restaurant or things like that. And just for example, I remember being not that old, probably 12 or 13 years old, and I'm out in the field digging, chisel plowing, whatever, and turned too wide and took out an REA pole. And so, you know, here I am as a kid sitting in a tractor with wires caught all over the place, not knowing if I'm going to be like electrocuted or what's going to happen. That's a lot. I mean, that's a lot for a kid to take on and deal with and just kind of roll with. And sometimes we overlook that when we're in farming communities because it's normal. But these kids are really tasked with keeping animals alive, keeping equipment running, understanding a lot of sign language from their fathers, running the equipment, and it's not always, it doesn't always happen without consequence. I'll just put it that way. And so it's important for those of you who work with youth to keep that in mind too, because they're often also a reflection of the stress that's going on in the family. I remember going home one day, getting off the bus, going into the house, and Mom was in the entryway, met us at the door, and she was crying. And I was probably in junior high, I suppose, and she said that they had been, and this would have been during like the 80s farm crisis, and they had been unable to secure an operating loan. And, you know, I remember at that time, my first thought was, what does this mean? You know, are we going to have to go live in town? Because to me, that was the worst possible scenario. I don't get my animals, I have to live next to people. But kids process these things very, very differently depending on their stage of development. So it's just also important to work with families, if you're seeing these kinds of things happening, to work with families to communicate in an age-appropriate way so their kids understand what's happening to the extent that that's possible and nothing is a shock or surprise. And I won't go through like substance use disorder, signs and symptoms. I think Beth did a really good job covering that. So warning signs. When you're working with farm and ranch families, there are some just telltale things to watch for that may indicate they're in trouble. And of course, the big thing that we're hearing about and we want to be prepared to intervene on is the threat of suicide. And there's a report from the Center for Disease Control that measures suicide rates by occupation. And in their 2016 report, farming and ranching was the highest occupation for suicide rates, even above military veterans, which I was really surprised about. But it's also important to remember that those numbers aren't necessarily accurate, because we know that a lot of deaths on the farm are due to accidents with equipment or hunting accidents, and sometimes those are suicides that are just set up by the individual to look like an accident. I just saw one video the other day that a farmer was talking about knowing he was going to lose his farm and looking at his son and his wife, and just in that feeling of desperation, he knew he had a life insurance policy sitting out there. And so his desire was to allow them to continue farming, even if it meant doing it without him. And so he did attempt suicide, but thankfully was not successful. But that, obviously, they probably still wouldn't have been able to keep farming. But when you're in that sense of hopelessness, you're not able to think things through accurately. So that's where we all come in, because we work with these people and we know them, and they sit in our offices or in our stores, in our churches, and we, it's our job to talk through these things with them and help them to understand that there is hope for the future. So some warning signs to watch for is overall, I'll just say, a change in baseline functioning. So if you've known somebody for years, they've been your neighbor or a fixture in your town or community, and they are just not behaving or looking like they used to, it's time to really pay attention. So they may be more isolating. Maybe this was somebody who was at Cenex every morning having a cup of coffee with the other farmers for years, and their attendance at these little meetings is now becoming kind of spotty, or they stop showing up. If you notice mood changes, that typically someone who's been pretty easygoing or easy to chat with or has a smile on their face, if that's not happening anymore, it's time to perk up. If you're noticing that they're selling off land or livestock and it doesn't seem to make sense, sometimes it does make sense for financial reasons, but if they're letting rental land go or selling land and it's just not fitting with maybe how they've been farming, that's a warning sign. If you notice equipment on the farm not being taken care of, there's tractors or equipment that's just sitting idle, their lawns and farmyards are in disrepair and that's not been normal, that's also a warning sign. Illness and injury, they're not sleeping, they're sleeping too much, using substances more than what they had been in the past, all things to pay attention to. Also lack of motivation, not as productive. I mean, this time of year, these guys are like chomping at the bit to get out there, right? I mean, my parents are still in Florida and we keep telling them don't bother coming home because you're not going out in the field anytime soon, but there's that drive to get out there and get the crop in the ground and get going on work. And if that's not happening with someone who normally, like if my dad told me that he wouldn't be back home until May, let my brother deal with it, I'm just done, I would worry, because that would be very unlike how most farmers are this time of year. If you're someone who is in a position where you're, maybe you have a business in town or you're with a bank or farm credit, things like that, and financially you're just noticing that they're not paying their bills, they're not keeping up. When you visit with them about that, just kind of be aware and watching for these other signs. And then of course, obvious statements of hopelessness or giving up. Sometimes people are ready. Sometimes people know this is not going to be my future. I can't keep up. I'm not going to get through this farm crisis. I've talked with farmers who made it through the 80s and maybe they're older now and there's not anyone in line for succession. So they just know they're going to be done. And that's okay, because there is life beyond farming, and sometimes it's Sometimes people can accept that, but sometimes they can't. And then of course a spouse or children exhibiting stress. And a lot of times it's the issues that a child presents or an adolescent that will get a family into therapy or accessing help versus what maybe they're experiencing themselves personally or within their marriage. So if you're someone who is in a position of working with kids, just be aware that often the kids are just exhibiting symptoms really of what's happening in the larger family system. Let me make sure I got everything there. Okay, let's talk a little bit about the barriers to seeking help, because for most farmers and ranchers, the last thing they're going to do is sign up to see a therapist and talk about how they're feeling. It's just not going to happen. So some of those barriers that exist in rural areas like North Dakota is there's just an obvious lack of resources. There aren't mental health therapists or addiction counselors in every community. People have to drive. And a lot of times, because of that last bullet point, they're workaholics, they're not going to take time to drive somewhere that's an hour and a half away for services, sit through an hour-long appointment, and drive back home, and you've lost a day of work. That would never happen, especially in like April through November. So it's important to recognize that that's a real barrier and to identify within your community, what do you have? You have churches, you have extension agents or extension staff, there's schools with often support personnel. It's really looking at what you do have and how you can build on those services. If there's a social service agency or human resource center that have services available that can help that barrier. Probably bigger is stigma, and that is alive and well in this population. No farmer wants their truck to be seen at the one mental health office or social service office in town, right? And so it's important that we have discussions like this at this level and in communities, just to try to do a better job at equating our mental health with our physical medical health. I have a daughter who, even when she was probably 9 years old and was dealing with some anxiety issues, and even at that young of age, she knew she did not want to go to the mental health agency. She wanted to go to the therapist at the clinic, the Sanford Clinic, because of how it's perceived. And so if our children are feeling that, we've got a lot of work to do in helping people understand it's part of your overall well-being. So that relates to stigma. And another piece that always comes to my mind when I hear stories about how a farmer maybe has suffered a heart attack or died or something serious has happened, and the neighbors all pull together, and you'll see the long row of combines heading down the road to take their crop off. That does not happen when a farmer enters treatment for substance use, is hospitalized for a suicide attempt, because it's not talked about. And the families often just don't even share that information, and they try to figure out how to keep things going on their own. So that's just another example related to stigma, that these people need to be supported no matter what the issue is. And then the cost is a barrier. Often farmers don't have, if they have insurance policies, they have very, very high deductibles. So for paying out of pocket for seeking services, it's a burden. There is a lack of understanding among mental health providers about farming. And I remember my dad talking about this, that the first therapist he went to didn't have a clue. And sometimes the solutions that we suggest might be viewed as too simplistic in this very complex world that farmers and ranchers live in. So it's important for mental health professionals in rural areas to read and gain knowledge just about farming as an occupation, so they get it and can relate better to the farmers or wives or kids that are coming into their office. So my next slide, I titled Serenity, and it's so funny to me because serenity, the definition of serenity is being, you know, very calm, at peace, and in all the little farm houses that I've been in over the years, there's often a plaque on the wall with the serenity prayer, right? But I know no farmer who I would call or characterize as serene. And so I'm guessing a farm wife bought that plaque, stuck it on the wall, hoping that it would make a difference in their home. So what, you know, we all know the serenity prayer, accepting the things we can't change and changing the things we can. Often with farming and ranching, the majority of our efforts mentally, emotionally, are spent thinking about and worrying about things that we have absolutely no control over. And they're all the things I mentioned in the beginning, the weather, the markets, totally out of control. And so this is just a little chart that is from a review of literature that was done in New Zealand in 2014. It's a fairly complete document, and I just love it because it really looks through all of the barriers of farmers seeking mental health help and dealing with mental health issues. But this little chart is a continuum that just goes from items that are outside of a farmer's control from like a national, global perspective, all the way down to what is within a farmer's control. Sometimes a farmer will tell you these things are not within their control, that worrying is not controllable, that working long hours and having the workload they do is not controllable. But that is the beauty of therapy, because therapy is all about changing the way we think. And I'll use my dad as an example again. When he didn't give up going to talk to somebody, and when he did find a therapist that he kind of connected with, what he learned was it's really about changing the way we think about things. So the focus, it's shifting your focus. So instead of focusing on what we didn't get done today and all that's sitting there in the future staring us in the face with rain coming tomorrow, our focus needs to be on what we've accomplished, and then make your to-do list for tomorrow and make it realistic. Shifting that mode from worrying to problem solving, so you can actually kind of feel that control. You can solve that problem, you can make forward motion. And it's important for people to see the link between their thoughts, their feelings, and their behaviors. So if we change our thinking, it will change how we feel and it will change how we act or behave. And they are linked to the point that is when there's success in therapy often, is when the patterns of thinking are changed and we're then able to deal with our feelings and actions in a different way. I feel like I'm talking really fast here. So how to help? And knowing that you're all in a very different mix of professions and organizations and agencies, the most important thing you can do is to reach out and listen. So when you have these people in your offices, you're interacting with them, they're your neighbors or your friends, you sit next to them in church, your kids are in sports together, it's really just listening and keeping your eyes open to the warning signs that might be going on. Oftentimes after a tragedy, people look back and say, you know, I was thinking this wasn't right, or I wondered about this, but nobody wants to say anything or do anything. So I just encourage you to reach out and listen. Avoid minimizing. When any of you have experienced anything that really is just overwhelming all of your resources and it's taking up your emotions and your thoughts, to have somebody tell you it's not that big of a deal, it'll be better next week, you'll get through it and you'll be having the same worries this time next year. I mean, it's just not helpful. So, you know, listening with empathy, hearing them, and then encouraging them to seek help or walking with them to seek help is much more meaningful. Asking questions, that kind of goes along with the empathic listening. It's just letting somebody know you understand and you get it, and that's very difficult, and what can we do? Let's just kind of map this out. What can we do to help you get through this? And the sooner the better. Letting warning signs go and not addressing it often can lead down the path of suicide or substance abuse. So it's like you're spiraling out of control, and to crawl out of that after it gets to a certain point is really difficult. And then engaging the family. You know, one thing that's happened over the years is, years ago, you know, female grew up on a farm, understood farming, married male who grew up on a farm, understood farming, and then they farmed together. And now it's very, very different. Most couples, the wives are often working off of the farm and other jobs to help support with income. Many have not grown up on a farm and may not fully understand the dynamics and the stressors. And I think a lot of times husbands tend to be kind of protective about not wanting to share their burden or their anxiety that they're carrying with their wives and family. But that just lends itself to problems later on when things are at a breaking point. So the more the family can be engaged, it might be conversations like, hey, you know what? There's not going to be a vacation this year. We just can't swing it. You know, we're in a bad time right now. This happens. We're going to cycle out of it, but it may take 5 years to cycle out of it. It's not going to be quick. It's just important to have the family understand that and be on the same page, so they're not just feeling like, what? You know, we take a vacation every year. What the heck? My friends are going, and now I can't go, and it causes a lot of issues. You know, there may be the need to sell new vehicles to get rid of some of the high payments, to buy used vehicles, to just downgrade lifestyle a little bit to get through a tough time. And if the family's not understanding why that's happening, it can lead to a lot of stress. Just looking. And then another thing, it's not on here, but how to help. Jenna, I think, talked about protective factors. And increasing those protective factors is so important. So making sure that person is surrounded with social supports, making sure they are physically healthy, eating the way they should be eating, getting medical checkups and medical visits, so that there's some preventative work happening there to help deal with what might be happening on the behavioral realm. And then there's just one other, I found an article that just kind of had a nice acronym for how family practitioners, is how they refer to it in this article, can help. And this is from a journal called the Forum for Family and Consumer Issues. It's a little bit dated, it's from '03, but truth is truth, right, no matter how old it is. So the acronym is APPLE, and it's be accessible, be personal, be professional. So this would be if you're in a professional role working as a family, with a family. Be linked, so know the resources in your community, know who you can refer to, and be empathetic. So listen with empathy and understanding. And then here are just some resources. The first one is the link to that New Zealand article that I told you about. It's a really interesting read. And then of course your medical providers, never underestimate the power of a primary care provider, because long before someone will walk into the office of a mental health professional, they will see their doctor. So it's important for our doctors in our communities to be aware of and included in discussions like this around mental health issues. So mental health providers, clergy, human service centers, and extension offices. That was very, very quick on a subject I could talk all day about, but are there any questions?
All right. Well, I think applauding won't help. So we'll just like wave or something to thank our speakers today. Thank you to Gina and to Beth and to Monica, all from Prairie St. John's. And again, you will be getting some links to resources coming up here, or just go to our mental health webpage, and after our Easter break here, we'll be getting all of these things up for you. So thank you everyone for joining us, and have a wonderful weekend, day, break, life. So we'll sign off now. Thank you.
Thank you from Logan County. Okay, so if you have your evaluations, I'll gather those up, and I have a...
Thanks so much, Carmen, for
absolutely. Yeah.
Good.
Okay, thank you. Let me this one and ask you to share it with you.
Can I give you one?
Okay.